Welcome back to part 85 of our 100-part CPC exam series. Today, we're taking a massive step forward in your preparation. Make sure to like, share, and subscribe to Decode Healthcare with Harshal. We have an incredibly focused explainer masterclass lined up for you today, so let's get right into the material. Okay, let's dive into this. We're transitioning away from our general guidelines to actually solving 4 high-yield exam scenarios under timed conditions. On our agenda today, the contrast exam trap, split billing and modifiers, complete versus limited ultrasound, and interventional radiology component dissection. Section 1, the contrast exam trap, avoiding CPT pitfalls. All right, here's our first scenario, and it's a classic CPC exam trick where reading the vignette too fast will absolutely cost you points. Imagine a patient getting a CT of the abdomen and pelvis. The medical note clearly states they drank oral barium contrast out in the waiting room prior to the scan, but absolutely zero IV contrast was administered. So how do you code the contrast? Is it with or without? The entire code selection literally hinges on just one single word: oral.
So the crucial point here is that oral and rectal contrast simply do not qualify as with contrast in CPT radiology coding rules. If a patient only drinks barium, your correct code selection has to be without contrast. You only get to use the with contrast codes when it's administered intravenously or intravascularly. Don't let that exam trap catch you on test day.
Moving on to Section 2, split billing and modifiers, tech versus professional components. This brings us to a really fundamental coding question. Who actually performs the imaging versus who interprets it? Picture this: a private practice radiologist reads an X-ray that was performed at an outpatient community hospital and then dictates the official written report. We've got 2 entirely different entities sharing the workload here. So who bills what? And this brilliantly illustrates exactly how the CPC exam tests component billing. Because that private radiologist provides the interpretation in the report, they're going to bill the CPT code with modifier 26 for the professional component. Meanwhile, the hospital facility, they own the equipment and pay the technical staff, so they report the identical code, but with modifier TC for the technical component. Now contrast that with a physician-owned clinic. If they do both the scan and the read with their own gear, that's a global billing scenario, and you wouldn't attach any modifiers at all. Section 3, complete vs. limited ultrasound, coding anatomy correctly. Now, this section really tests your anatomical awareness. Let's look at the requirements for a complete abdominal ultrasound, code 76700. The CPT descriptor strictly mandates that you must visualize the liver, gallbladder, common bile duct, pancreas, spleen, kidneys, and upper abdominal aorta or IVC. But what if, like in our current scenario, the sonographer goes in for a complete ultrasound, but the pancreas and spleen are totally obscured by bowel gas and just can't be evaluated? Well, this triggers a strict CPC decision rule. Missing even one required organ, even if it's due to something completely unavoidable like bowel gas, forces you to change your coding approach. Because not all the required anatomical structures were evaluated, you have to drop down and report the limited abdominal ultrasound, code 76705, instead of the complete code. Or, depending on the specific documentation, you might append modifier 52 for reduced services. Just remember, never code a complete study if the anatomy isn't fully documented. Section 4, interventional radiology component dissection, selective catheter codes. Okay, we're shifting to what's often considered the most complex topic in the radiology domain because of its heavily layered coding logic. Here is our final high-level scenario. A radiologist accesses the right common femoral artery, pushes the catheter up into the aorta, and then selectively navigates right into the right renal artery for diagnostic angiography. How do we logically build this code? I really want you to think about the path taken and the final position of the catheter. Let's move through the steps and see how this builds, because it's definitely not a one-code-fits-all situation. Step 1, we have the access in the femoral artery. Step 2, non-selective advancement into the aorta. But step 3 is where the coding magic happens: selective navigation into the right renal artery. You always code to the highest level of selectivity. So the surgical component here is the selective first-order renal artery catheterization, code 36245. And remember, you've got to carefully distinguish this surgical placement from the radiological supervision and interpretation, or SNI, which is often coded separately depending on the bundling rules. To wrap things up, here's your high-energy, rapid-fire cheat sheet. Lock in these 4 mental frameworks to instantly recognize these exam traps. 1. Oral or rectal contrast always means without contrast. 2 and 3.
Radiologist read-only, that's modifier 26. Facility equipment only, that's modifier TC. 4. Missing just one single ultrasound organ means you drop down to a limited study or use modifier 52. And finally, for IR catheters, always code for that highest, final selective placement. Definitely keep this checklist handy for your studies.
And that brings us to the end of today's explainer. Coming up next time in Part 86, we're tackling pathology and laboratory coding guidelines, focusing specifically on organ or disease-oriented panels and drug testing. I'll leave you with this thought to chew on. How does one single missed analyte completely change the coding for an entire comprehensive lab panel? We'll uncover that trap next time. Until then, make sure to like, share, and subscribe to Decode Healthcare with Harshal and keep crushing your exam prep.